Let's talk about follow-up post-GAE and subjective scales like WOMAC, KOOS, NRS, VAS versus objective functional testing. So I'm going to give you subjective scales, so I'm going to give you objective functional testing, and I'll let you explain what that exactly means. Oz, why don't you start?
Sure. Yeah. I think on every topic, Sid and I have basically come and met in the middle because we probably have very similar thoughts on things.
There's been a little bit of spice. There's been a little bit of spice.
No. But it's good. I think I'm we also obviously clearly differ on some things, which is fun. But I think, and this might be where we might differ a little bit. I think I work very closely with some rheumatologists on some of my studies. And I've learned a lot, about OA and how they think. And obviously, we're sort of new entrants to this game. We've sort of just become quote unquote OA experts in the last few years. And they've been doing this for decades. And the reality is they view GAD currently as a pain intervention. This is a treatment that we are doing to reduce pain associated with OA. It's not disease modifying. We don't have any evidence to suggest that. And there's nothing that's disease modifying or curative for OA. So if it's a pain intervention, really obviously arguably the most important metric to measure is, did your pain get better? I think to tell somebody, hey, you can walk a block farther, you could do all these other things, while it's nice for a paper, I'm not sure how much it does for a patient if they say, well, I'm not very, my pain isn't, reduced by 50% or whatever.
I agree that the pain is the most important thing. The problem is that we all know this. The pain is amazingly subjective. It's amazingly subjective the second you walk into Dr. Ahmed's office. And I'll tell you why, and don't take this personally, but because he's a physician and you want to please your physician. I know that sounds ridiculous, but it's true. Your pain is going to be different at 8 o'clock versus 4 o'clock. It's going to be different when you're seeing him at University of Chicago in January when it's 5 degrees outside versus August when it's 85 degrees outside. And so if you just say my pain is better or worse, I can game the system. I can do the GAE. I can evaluate them in January at 4 p.m. in Oz's office when, the guy whose labor has been working all day and comes into the office when it's cold. And then I do the GAE and I'm going to evaluate him exactly 6 months from now at the end of June. And I'm going to make sure he has an 8 a.m. appointment and he's going to be better. And I could do nothing and he's going to be better. So I think the challenge is that this whole concept of pain, we absolutely want to make people, they need to feel better, right? Like that's the goal. But it's super hard to do this objectively. And that's why I feel like we do need some kind of objective scale. The challenge with that, right? The flip side is that the objective scales we have, the two that are most commonly used in the orthopedic literature, one is called KOOS, K-O-O-S, the other one's called WOMAC, are both, let's just say, they're old and antiquated. And they have not been updated in I don't know how long, right? So if you were to actually look at the questions and look at them yourself, you'll realize how kind of almost ridiculous they are. I'll give you some examples. One is, hey, Oz, how much pain do you have getting in and out of your bathtub?
Yeah.
Right? I mean, when's the last time you took a bath?
Right. No, I know. There's like shopping questions.
Well, yeah. Do you have pain shopping? I'm like, I don't know. I'm going to go shopping right after this webinar on Amazon. Like, I have no pain, right, when I shop on Amazon. So, like questions like that are stupid, right? They might have been relevant in 1980 when my parents, I think, still have a bathtub in their old house. I mean, so, but they're not relevant in 2025, right? So these need a refresher. They need an update. And I don't know if there's really an initiative in the rheumatology and orthopedic surgery societies to update these things. And in an ideal world, it's always talked about, well, why don't we create a new scoring system? That's great. But nobody cares what we think at the end of the day, right? Like, we don't want to kind of just pat each other on the back. The goal is to convince the non-believers, the naysayers, right? The people who have doubt that this might actually benefit patients. And you can't do that when you go, well, I did develop my own scoring system, so we should use that, right? That's unfortunately not going to work. So despite those limitations, I still think we need to use these scoring systems. If you're doing research on this, you absolutely need to use it because otherwise you have no way of validating this. It is nice to see someone, we use WOMAC. It's on a 96 point scale. Don't ask me why they didn't make 100. They have 24 questions. Like, dude, you guys couldn't add in one more question to make it 25. So it's out of 96. And when someone goes from a 56 to a 5, and they're like, yeah, I basically have no pain, and you have this numerical validation on a validated scoring system, it is kind of a nice home run to see.
So we're going to use functional testing or objective testing, Sid. What do you like to use?
So we've used objective. There's functional testing like chair and walk tests and stuff like that. We have not done that. I think they're great ideas. While I don't have experience doing it, I'm a big proponent. I think it simulates real life more. As long as you can reproduce it, right? Which may or may not be able to do. So if you can reproduce it, let's say you can get one person in your office to do it with every patient, so they do it the same way. I think that's a great idea.
Yeah. Well, and I know some groups in the U.S. are doing it. I think UPMC group is doing that in the U.S. There is a precedent in the literature. I think it was a Landers paper that included functional testing, right? So there is a precedent. I think a lot of us just haven't gotten there yet. But to your point, I think a lot of us, hopefully will get there in the near future. And we're starting to do that in our practice as well. And we don't know necessarily what to do with it yet, but starting to track some of those outcomes or metrics.
Just as a corollary, there was the GLP agonist for weight loss. There was a paper in the New England Journal that came out last month looking at GLP agonists for knee arthritis, right? And their benchmark was to use these objective scoring scales like WOMAC and so on. So they're using it, like Eli Lilly is using it, New England Journal is. So as crappy as they are, this is at least what is accepted in the medical community. But I agree. The chair test, walking test, I think those are great tools. I would like to see them becoming more accepted because I think they simulate real life better.
So kind of on that topic, what about psychometric testing? I think the Genesis study made some waves talking specifically about metric testing. There's a fair amount of literature in the surgical world that uses psychometric testing and correlates outcomes with psychometric testing. Although the Genesis data showed us, I think, opposite of what we expected in that realm. Will it help select patients? Oz, you got the yes side, Sid, you got the no side.
I think the psychometric stuff is important. I think it's very well established. I think Sid just said it, right? Like pain is incredibly subjective and there's different types of pain, right? There's, when you have OA pain that's become chronic, neuropathic, it becomes basically, it goes to the brain, essentially like the dorsal root ganglia and all the, all the pain receptors in the brain. And so it becomes a centralized process. So I think doing things like the pain catastrophizing scale, assessing for neuropsych component of pain is probably important. This goes back all the way to how we started this conversation about, there's a subset of patients who don't get better with GAE, and probably doing psychometric testing might help identify those people who you might treat locally, the synovitis, high five yourself on the way out, but then it does nothing for them because their pain is all sort of coming from the brain.
I mean, I agree with you. I think from a practical standpoint, it's going to be hard, right? These aren't tests. So Mark Little did this as part of his Genesis trial, and the data it's a little bit hard to understand, admittedly, but it's fascinating. You realize that, you're not dealing with things like tumor response when I treat liver cancer, right? Like is it bigger, smaller, et cetera. It's way more complicated than that. I have fears that it's a big barrier though, right? This stuff is not readily available. It's not easy for us in IR to integrate into. We're kind of this redhead stepchild of a specialty, as we all know, right? So this is not part of our wheelhouse. I think if it was readily available, I'd be all for it. And it definitely could help us choose patients, especially for trials. If we're going to, optimize and try to get these perfect trials, I think this is a great way to say, if you undergo this testing, we can kind of help select patients who should get this procedure or not.
Yeah, great points. It's also easy for us in the, quote unquote, ivory tower in academics, right? We had, to take a little bit extra time in clinic, do some of these things. The average IR in 100% clinical practice that has no time is just trying to get through the day. Is this actually feasible?
I don't know about you, Kavi. I'm getting murdered here. So I wish I was in an ivory tower. Yeah. We have worked. Yeah. We don't have downtime. Downtime comes out of family time. So
good point. Same.
Look, so seriously, if I were to do that, I would need, let's say on a research side, I would need funding, grants, et cetera, right? That's not that easy. That's always easy. Everyone's like, just go get a grant. Yeah, that's nice try. So it's actually, or you have to find collaborators who are into it, right? Meaning not people not in my department. That's also very hard to do, right? Like Oz actually has done a 10 times better job than I ever have in terms of finding collaborators because he's nicer than me. And it's very hard to do that, right? And so it takes an extraordinary amount of effort, even in academics where the three of us are, to get that type of project going.
Yeah, great point. That's a great point.